Hi guys, it's good to be back. We're about to do the next lecture for mobility. This one will cover spinal cord injuries. I have managed to set myself up in a virtual paradise. I got my computer working on this. So if you see, this is the driveway up to my house. So I'm sitting in my front drive delivering a lecture to you, which is kind of unusual. We don't get to do that very often. I'm going to break here and I'm going to share my screen. And I'm going to we'll go talk through our PowerPoint on spinal cord injury. Bear with me as we get this started. Okay, spinal cord injury. The opening slide simply shows you pictures of spinal anatomy and what levels of injury will do. Is this to prompt your memory when we talk about, my background's messed up. This will prompt your memory when we talk about what's going on and why an anterior cord injury would cause a different effect on motor and sensory neurons than a posterior cord injury or a lateral injury, and also the level of injury, why a C-spine injury affects some parts of the body and a L5 injury affects different parts of the body. You don't have to have all of these memorized. I have a later slide that actually shows you which ones I want you to know, okay? But if you'll remember your anatomy, you can see sensory nerves come into the posterior root and the anterior root coming into the anterior part of the spinal cord is the motor neurons. And in certain pathways, some nerves cross and some do not. And some nerves cross high and some nerves cross lower. So when we talk about this later on, we're going to talk about some syndromes where they have pain on one side, but vibration sense on the other side and things. It's kind of an interesting thing. It all depends on which neurons cross where and what level the injury is. Okay, when we talk about a spinal cord injury, SCI, one way they classify that is the mechanism of the injury. What happened to cause the injury? Was it a flexion injury? Was it a hyperextension injury? Was it a rotational injury? Was it extension and rotation? So all of those things can differentiate what part of the spinal cord was actually injured. If I do this, then the anterior cord is more likely to be stretched and pulled. If I do this, the posterior cord is going to be stretched and pulled. So the type of injury and whether it was a twisting, bending, moving injury can affect the type of response the patient has. We also know that there's two things that cause spinal cord injury. There's a direct injury and a secondary injury. The direct injury is the actual act of injury to the spinal cord, whether it was a knife, a gunshot wound, an ice pick, whether it was the pulling or crushing injury. That's the actual damage to the cord and the surrounding bones itself. The secondary injury comes from the process of inflammation that starts immediately after the injury. Anytime there is a traumatic injury, then hemorrhage, because a blood cell disruption is going to happen. You're going to have blood enter the white and gray matter in the spinal column, in the spinal cord. And because there's a traumatic event, the axons were disrupted. And when the axons are disrupted, that ruins the myelin sheath and it disrupts the nerve function and can actually damage and kill the nerve. Because there's a traumatic event and edema and the body is saying, ooh, bring in the cavalry, bring in more blood flow, release the inflammatory cytokines to promote healing, what happens that produces more edema. We've talked enough about inflammation now. You understand, causes capillary leakage, more fluid leaves the vascular space, goes into the tissues. The cytokines are activated, bradykinin, histamine, prostaglandins, all those pro-inflammatory products, and they provide more edema and more inflammation, and that causes a worsening of the ischemia. Every time you have more edema, that puts more pressure in this very enclosed space, and that causes more hypoxia of the tissue. And when you have hypoxia of the tissue, then you're going to produce lactate, serum lactate, or lactate is going to be excreted into these cells, and the lactate is going to cause more vasospasm. Vasospasm means the muscles are moving and using oxygen, and that oxygen use is going to cause more hypoxia. And to top it off, there's going to be a cell death over the next couple months, weeks to months. And that cell death, because as cells are destroyed, then there's a cell death and a sloughing of the cells. And as that happens, the nerve cells are demyelinated. And quite often, they're left with a glial scar, a scar that won't allow it to remyelinate, and it gives a permanent neurologic damage. That whole process of secondary image takes time, and it can go on for weeks. One of the things we want to do is, after the initial injury, is we want to stop that secondary injury as quickly as possible. And when we want to get that patient stabilized, if we can get them into surgery, stop that process of inflammation so we can prevent as much permanent damage. After the injury, the patient can continue to improve as long as the secondary damage isn't going on. We can get some degree of healing and some improvement in function quite often. Of course, peds are a little bit different, and they have less bony structure and more ligaments, and their growth plates aren't completely closed. So those are other things you have to consider if it's a pediatric spinal cord injury, that it can affect their growth or their ligaments. So another way we classify injuries is by what is paralyzed. So tetraplegia is a newer term for quadriplegia. Tetraplegia is all 4 extremities are paralyzed. Okay? Paraplegia is 2 extremities are paralyzed below the level of the injury. The higher the injury, C1 is way up at the very top little spinal vertebral area. And it goes all the way from cervical to thoracic to lumbar to sacral, and then finally coccygeal, but that doesn't really affect the spinal cord because all the cord is left by them. What we really see then, depending on how high the injury, we're going to see a level of dysfunction. Tetraplegia is when the cord is not completely injured, it's only partially injured, and so you might lose complete function in your legs, but one arm will still have function, not the other. So, that's called triplegia. Tetraplegia or quadriplegia, all 4 extremities. Paraplegia, the bottom 2 extremities. And you may have some upper body movement. You may have full range of motion and movement in your hands, or you might just have partial movement. It depends on how high the injury is. The higher the injury on the back, the more permanent and the more disabling it is. So this slide, I really think is helpful. C1 through C4 is going to affect your lungs and your diaphragm. If your patient has an injury at C1, 2, 3, or 4, they are not going to be able to maintain their own airway. They're going to need immediate intubation and probable ventilatory support with a ventilator. So that is the most life-threatening injuries because it impairs your ability to control your own airway and own breathing. So C1 through C4 affects your breathing. The other little arrow and picture I have here is right there at the lower T, T12 to L1. And you can see there, if you have an injury below in the lumbar area, they have control over bowel and bladder. It may not be perfect. They may have to have some equipment, but they can maintain some control over their bowel and bladder. Above that, their incontinence is a bigger issue. So if we're looking at life changes and the way your life is affected from the spinal cord injury, then we're talking C1 through 4, respiratory. At T12 and below, we're going to have bowel and bladder function. Above injuries higher than that, we're going to have incontinence issues. The rest of it is just going to depend on how much movement based on which dermatomes are affected by the nerves that are damaged. So we talk about spinal cord injury. We also talk about a complete injury or an incomplete injury. A complete injury means that there's no motor, no sensory function below the level of injury. Nothing. They cannot move. They cannot feel. An incomplete spinal cord injury means that we've preserved some sensory function below the injury, and there might be some involuntary motor movement below the level of injury. So that, it's better to have an incomplete fracture, incomplete spinal column injury than a complete one. Complete one would be worse. So if you have an incomplete spinal cord injury, so a complete spinal cord injury, loss of all motor and sensory below the level. Incomplete is mixed motor and sensory. And there's syndromes. There's 5 major syndromes. Only 3 are the most common. The cauda equina and cauda medullaris are low spinal cord syndromes, and they're not as disabling. But the Brown-Séquard, the central cord, and the anterior cord syndromes, more common with higher spinal cord injuries. With contralateral means the opposite side. Ipsilateral means the same side. This is an incomplete spinal cord injury. So when it says contralateral, it means on the opposite side of the injury. If it says ipsilateral, it means on the same side of the injury. So with a Brown-Séquard injury, so I have hurt my spinal column on the left side, my left side. When that happens, then I'm going to have loss of pain and temperature below the injury. So I feel no pain and I don't control temperature below the injury. I can't feel if it's hot or cold below the injury on the opposite side. But on the left side, I've lost my motor function, touch, pressure, position, and vibration, but I might have pain and temperature. And on the opposite side, I don't have pain and temperature, but I've lost vibration, touch, pressure, and motor movement. Isn't that interesting? It's because of which neurons cross the spinal cord and where they cross. With the central cord, you're going to have motor weakness and impaired sensation in your upper extremities and burning pain in your upper extremities, but the lower extremities are fine. They're not affected. And the anterior cord syndrome, you've injured the anterior portion of the cord. Now remember, motor and sensory neurons come in through different pathways. So an anterior cord syndrome is going to give you a loss of motor, pain, temperature, and sensation below the injury, but they can feel touch, vibration, and a sense of position still. So if it's vibrating or somebody touches them, they're aware of it. So it's pretty fascinating depending on which neurons are affected. So a lot of people get confused. They're like, well, they have a spinal cord injury. How can they feel me touch them? Or how can they know where their sense of body and space is? Well, it depends on if they had a complete or an incomplete injury and what area of the cord was affected. So in general, the most common signs of an acute spinal cord injury is flaccid paralysis below the level of injury. Floppy. They aren't tense. They can't hold tone. The muscles are just floppy below the level of injury. Now that's initially, may not be forever. A loss of spinal reflexes below the level of the injury. They cannot sweat any longer below the level of the injury. They cannot feel below the level of the injury, and they do not have sphincter tone for bowel and bladder unless it's a very low spinal injury. So we are going to do an ASIA scale. An ASIA scale looks at the motor and sensory symptoms and gives them a ranking, A through E, of how significant and severe the spinal injury is. So far in this particular unit, we've talked about the Morse-Fall scale. We've talked about the ASIA scale now, which is spinal cord injury. So there's different scales, and that's one of the things you'll see on the NCLEX blueprint is the use of standardized scales to measure a patient's activity and to assess the patient. So those are 2 that we've talked about in this unit so far. When we move on down the semester, we'll hit a couple more. So remember, C3, C4 and above, you're going to have lost your respiratory function. They're going to need a ventilator and an artificial airway. Their cough is going to be impaired. They're not going to be able to manage their airway secretions. And so suctioning is going to be needed. Most spinal cord injuries have an areflexic, absent muscle contraction to their bladder. Most of them, it's just a flaccid bladder, so they cannot control. Some patients have a spastic bladder, where it'll go, but it's like now, urgent spasticity. Or there's a lack of coordination between the bladder contracting and the ability of the sphincter to relax and let the urine out. Some spinal cord injuries don't allow the bladder contraction and the sphincter relaxation to happen together. So a neurogenic bowel is a patient that has increased sphincter tone, decreased peristalsis, increased rectal compliance. The rectum is relaxed, and so it can just store a bunch of stool, and the sphincter has increased tone, so it won't let it go. They have an absence of sensation, so they can't tell their bowels are full, and they're chronically constipated. Another thing that will happen to a spinal cord injury patient is they're very high risk for thromboembolism, venous thromboembolic disease, VTE, or thromboembolism. And that's because of the immobility and the hypercoagulability from the injury. So, we've talked about that in other units. We'll talk more about it in a minute. Some patients continue to have pain. And remember, depending on the kind of cord syndrome, well, they may have pain below the level of injury or not. If it's nociceptive pain, it's dull, aching pain when they move, cramping in their abdomen. They might have deep visceral pain. They also can have neuropathic pain, which is pain that's directly from the damage to the cord, and that's shooting, tingling, sharp, burning pain. So neuropathic pain is kind of like the paresthesia, sharp, tingling, shooting pains, tingling. The nociceptive pain is tenderness, cramping, headaches, visceral, deep organ pain. So pain is real, even though they've had a spinal cord injury, and you want to be sure that we treat that pain. It does, just because they have an injury doesn't mean they don't have pain anymore. And so another thing that's going to happen, depending on the level of injury, is they probably have lost some degree of sexual function. They may not have any sensation anymore. They may not have fertility anymore. They may not be able to have sexual performance anymore. So here's our ASIA impairment scale. It gives them 0 to 5 of muscle strength on the bottom. The bottom little thing tells you how strong your muscle strength is on a scale of 0 to 5. The ASIA impairment scale is the A through E at the top. And what it's looking at is A is a complete cord injury. No motor, no sensory. At sacral levels, you have no motor and sensory function. So we know there was a complete cord transection. An incomplete B, incomplete C, D, and E. E is a perfectly normal neurologic spinal cord exam. A B is an incomplete injury where you have sensory but no motor at sacral S4 and S5. A C is motor may be preserved, but most of the muscles don't have much muscle strength. It's below a 3. A D is the motor is preserved and the muscles can function at 3 or above. And then an E is a perfectly normal. So if I'm going to have a spinal cord injury, I want a D. I don't want an A. I want to have function. So a patient comes in and they're complete motor and sensory loss below the level of injury, and they're having respiratory difficulties or whatever else. We're going to do a CAT scan and or an MRI as quickly as possible to determine where the level of the injury is. We might have to deal with airway management first. We're fairly soon going to do an electromagnetic study, an electromyelogram, to determine how well electric impulses are carried through the spinal cord itself. We're going to do x-rays of the spine, a pulmonary function test. Even if they are C1 through 4, we know we're really worried about that respiratory status. But if they're a C5 or C6 or a high T injury, we may not have good respiratory excursion. We may not have strong diaphragm. We may not be able to fully expand our lungs. So we're going to want to do pulmonary function testing to determine their tidal volume and the depth of the respirations. We'll do ABGs, especially the higher the cord injury. We want to know how well they're exchanging gases, retaining CO2, or are they acidic or alkalytic. So emergent care. So if a patient has C1 through 4, intubate them, get a ventilator by. C5 through T6, make sure you have a respiratory therapist nearby, oxygen, airway management possible. We're going to make sure we have tools to help them with their respiratory support. Put them on an SpO2 monitor, check their ABGs, monitor their end-tidal CO2. My allergies are bothering me today. I know I'm not supposed to be touching my face, but my nose is itching while I'm talking to you. Okay, need to wash my hands thoroughly and not touch anything else. We're also going to, if the patient's head needs to be elevated for respiratory support, a Trendelenburg is turning someone upside down on a flat scale. You tip the bed upside down. A reverse Trendelenburg is where the feet go down and the head goes up, but we're not bending anywhere along the torso. So we have the patient laying flat in bed, and they seem like they need their head up for airway management, we'll put them in reverse Trendelenburg, so we just tip the whole bed upright as compared to elevating the head of the bed and leaving the feet flat. We don't want to bend that spinal cord. Remember, they're going to be log rolled all the time. They're going to need an IV access because it's very possible that they'll have neurogenic shock and they will need some type of IV medication to support their vital signs. We're going to maintain their blood pressure, so check their vital signs frequently during these early stages. And then we're going to put them on a backboard. We're going to immobilize their C-spine with a hard C collar. And if we have to turn them, they're going to be log rolled. If we are able, if they're a good surgical candidate and they're stable enough, we're going to try and do surgery as early as possible to relieve the compression of the bones and the injured area so that they don't have secondary injury. Remember, primary injury, the initial tear or injury to the spinal cord, secondary injury from the ischemia and the swelling and the inflammation afterwards. Early surgery to relieve the compression can help restore and restore their function and prevent some of that secondary injury, preserve some of their normal function. We also can put them in halo vests, halo collars, Gardner-Wells tongs, whatever we have to until surgery to keep them from turning their neck. Some patients, if they have like a central cord syndrome, can actually wear a halo device when they go home. It sounds like we should give them steroids. There's no actual evidence that steroids work in this situation, but they're commonly used to decrease the inflammation. We don't have any good, strong evidence-based practice supporting the practice, but they're used all the time. So you would expect to give them. Again, we're going to send them as soon as possible for x-ray studies to determine the extent of the injuries. This was a traumatic event. They might have had a gunshot wound. They might have fallen off a horse. They might have run into a tree when they were skiing. We might have jumped off a diving board and hit their head in the pool. We don't know the extent of the other injuries. So remember the A, B, C, D, E of the trauma assessment that we talked about with fractures. We need to expose them and look at the rest of their body to see if there's other injuries, be aware of what else is going on. We want to control any hemorrhage that might be happening. They could have not just gotten a spinal cord injury, they could have severed a leg and be bleeding. And so we have to control the bleeding because we don't want them to bleed to death while we're immobilizing them. So we're going to drop an NG tube. An NG tube can be hooked to suction to keep their stomach empty. So emesis isn't a problem. If somebody's got to throw up, they're trying to move their neck, trying to move their back, heaving. And so we don't want them doing that. We've got them immobilized and in a log rolling, and it's very tough to throw up in that position. So we want to keep their stomach empty. We want to prevent aspiration, and NG to suction, low intermittent suction can do that. It also will keep their stomach empty. One of the major complications after spinal cord injury is a paralytic ileus. After any major traumatic event, a paralytic ileus can occur. I believe you studied that in level 2 when we were doing perioperative nursing, and we talked about how surgery can sometimes cause the ileum of the stomach to just stop moving. So they get bowel obstructions because their ileum stops moving. It's very frequent. It's a frequent occurrence after spinal cord injury. By keeping their stomach empty and on NG to low suction, it actually can delay the development of a paralytic ileus. And if we have an NG tube in, we can feed them earlier. If they're unable to chew and swallow and manipulate foods, or their sensorium, their neurologic level of functioning isn't high enough to eat, we can tube feed them. And early feeding has been shown to decrease their length of stay and improve their clinical outcomes. So we want early feeding within the first few days. Because one of the things that happens with spinal cord injury is the sympathetic nerves cease to be able to get their message up to the brain to have autonomic outflow from the sympathetic nervous system. And if that happens, our patients have trouble with thermoregulation. They can't sweat, they can't vasoconstrict, they can't they can't control their own thermal controls. So we need to check their temperature every 4 hours. Probably have them on a heating/cooling blanket so we can get them hotter or colder as they need to. They develop poikilothermia. They take on the temperature of the environment. We need to make sure they have covers if the environment's cool, that they have adequate air circulation because they can't sweat. So if they get hot, we need to be able to cool them down. They're definitely get an indwelling catheter because they're not going to be walking to the bathroom anytime soon. And we'll put them on deep vein thrombosis, venous thromboembolism prophylaxis, which means we're going to give them some Lovenox and enoxaparin to prevent the formation of blood clots. We're also going to put them on stress ulcer prophylaxis. So we're going to give them some PPE, proton pump inhibitors, PPIs, or antihistamines like Tagamet, Zantac, ranitidine, cimetidine. But the PPEs are more common, and not PPEs. I've got personal protective equipment on the brain after this coronavirus stuff. PPIs, proton pump inhibitors, are going to be given to decrease gastric acids. When somebody has a big traumatic event and they're hospitalized for a period of time and their whole life is changing, they get stress ulcers. That's because of the constant release of acids in their stomach from the stress. And so by putting them on proton pump inhibition, it decreases hydrochloric acid production in their stomach, and it helps prevent stress ulcers. So they're not as likely to get a GI bleed on top of paralysis, poor respiratory function, poor bladder and bowel control. Because they're now on bed rest, we're going to be worried about pressure skin management. So we're constantly going to be paying attention to their skin. We might put them on gel cushions, make sure they got specialty mattresses so that they don't get pressure ulcers. We're going to definitely reposition them every 2. Going to keep their skin dry. You remember on the Braden scale, moist skin is one of the biggies that cause breakdown. All right, when a patient has a spinal cord injury, there are 2 kinds of shocks that we often see. The first one is shock that isn't really shock. When we say shock, most of the time we're thinking about rapid pulse, dropping blood pressure. And that is true. Septic shock, neurogenic shock, neurogenic shock may not be rapid pulse, but shock, the dropping blood pressure, the lack of volume in your vascular space, and poor perfusion, that kind of defines shock. But a spinal shock, I don't know, somebody named this a long time ago and it's just stuck around. It happens immediately within a day or 2 right away to the first couple of days after an injury. They have what we call spinal shock. The spinal cord just goes, ah! And you get complete flaccid paralysis, a loss of your deep tendon reflexes, a loss of all sensation, a loss of all sphincter tone below the level of injury. Below the level of injury. The peripheral nerves are completely unresponsive to your brain signals, so they can't tell us to do anything or feel anything. That can last days to weeks. But typically, a first couple of days, you get this complete loss and flaccid paralysis. Then a couple days later, you begin to get some spinal reflexes back. The 2 spinal reflexes that come back first are the plantar reflex, the one where you scrape the bottom of the foot and the toes scrunch down, or the bulbocavernosus reflex, which we will not be checking, but what happens is the anal sphincter tightens in response to clitoral or penile compression. About a week to 4 weeks later, after they've had this flaccid paralysis, so 1 week to a month later, they begin to get hyperreflexia. Remember, they had no reflexes. Now they begin to get hyperreflexia below the level of the injury. And after that, then they get spastic paralysis below the level of injury. And that can last for up to a year and sometimes a little longer. So what we're going to do for spinal shock is physical therapy, occupational therapy, depending on what kind of paralysis they have and how their reflexes are. We're going to keep them moving, start retraining their body, trying to get as much function as possible back, teaching them to learn to use adaptive devices, giving them antispasmodics to take care of the spastic paralysis. That's not a true shock. It just means that there was a shock to the spinal cord, and so now they have these symptoms. Neurogenic shock is a true shock. You guys studied hypovolemic shock in level 2, somewhere in periop, I believe you talk about that, with blood loss. Might have been in fluid electrolytes. You have blood loss or fluid loss. And because of that, your blood pressure drops, your pulse rate increases, and is a downward spiral. As your blood pressure drops, your pulse rate increases. That means you need more oxygen. And if you can't get the oxygen, your body says, ooh, let's make your heart rate go up even faster. And that decreases your stroke volume with each beat, which further drops your blood pressure, and it's a cycle. That's hypovolemic shock. There are other kinds of shocks that are called distributive shocks. Shocks where the body fluids are just distributed differently. With neurogenic shock, they haven't truly bled out. They haven't lost a lot of volume. But what's happened is we damaged the spinal cord, and the sympathetic nerves can't get from the brain down to all the vascular spaces. So everything dilates. They lose sympathetic nerve innervation. All they have left is parasympathetic tone. So they have vasodilation, venous pooling, a lower cardiac output, a low blood pressure, bradycardia. Every other shock on the face of the planet causes tachycardia. Neurogenic shock causes bradycardia because it's blocking the sympathetic response. With every other kind of shock, the sympathetic response is present, and the tachycardia occurs as a compensatory mechanism. With neurogenic shock, we've blocked that spinal transfer of the sensation, and the sympathetic neurons cannot get their message out to the rest of the body. So bradycardia is the order of the day, and they can't control their temperature control because the sympathetic nervous system is what makes us shiver and constrict and bring our temperature up, right? So this patient then will have vasodilation, low cardiac output, low blood pressure, bradycardia, and they can't control their temperature. It will last for 1 to 3 weeks, and we have to treat it. We can't just let the patient die with a bradycardia and hypotension. They might have a pulse of 30 and a blood pressure of 90/40 when we find them, and we have to treat that. So the treatment for it is vasoconstrictors. The most common vasoconstrictor we give them is phenylephrine, which is, yes, actually a nasal spray that vasoconstricts your blood vessels in your nose. It brings the blood pressure up. It vasoconstricts. We can also give vasopressin, dopamine, and norepinephrine. All 4 of those are used. Phenylephrine and norepi, very commonly used here. Fluids, they haven't lost fluid. With a lot of shocks, we dump fluid into the patient. This patient, we're going to be cautious about that. We can give them fluid to maintain their blood pressure, but we don't want to overflow them with fluid. If their pulse rate remains low and it doesn't respond, they're still trucking along at 30 and 40 and they aren't having good cardiac output with that and they're symptomatic, then we're probably going to give them atropine, which is an anticholinergic. It blocks parasympathetic. Remember, everything's parasympathetic, so if it blocks parasympathetic, it will cause the heart rate to elevate. So atropine is the drug we give for a low heart rate. But that may or may not work because they don't have sympathetic outflow. So quite often we have to do a cardiac pacemaker. We can put a temporary pacemaker on with pads on their skin, or we can run a temporary one through their IV line through a central line directly to pace the heart through the IV line, or we can put in a permanent pacemaker if they need it. But this is a temporary problem, so most likely we just need a temporary pacemaker to control the heart rate. And so after that, we're just treating the symptoms as they come up. So be able to differentiate neurogenic from spinal shock and understand how to treat them. Okay, I said methylprednisolone, a corticosteroid. Again, no proof it works, but we do it all the time. Enoxaparin to treat the thrombus, fluid boluses with caution for the low blood pressure. And if we need to keep their mean arterial pressure up enough to perfuse their brain, because MAP, mean arterial pressure, is the level, we have to keep a 65 or higher to perfuse our brain. And so if our mean arterial pressure drops below 65, we've got to treat that low blood pressure. Now we're going to talk more about MAP when we do intracranial regulation, because we're actually going to have to calculate it for some of our test questions and some of our activities that we're doing. But the vasopressors, again, that we're going to give, phenylephrine, norepinephrine, vasopressin, this is a repeat. This slide repeats a lot of the things I've already said. So if the patient's having respiratory difficulty when they present in your ER or on your floor, then we're going to check breath sounds, make sure they have bilateral breath sounds, get their ABGs, make sure we measured, done bedside pulmonary function testing, get a good tidal volume measurement so we know what their average tidal volume is. See how their skin color is. Are they breathing enough to keep from being blue? Do they have an unusual respiratory pattern? Did they get a head injury at the same time? We don't know. And so what's their respiratory pattern like? Do they have irregular respirations, apnea? Are they having gasping respirations? Is it wet? Do they need to be suctioned because they can't swallow their own secretions and manage their own airway? If they can't cough well, as the patient goes into rehab and recovers, we're going to start teaching them and helping them with augmented coughing. You can do a breath stacking, and that breath stacking on top of each other builds up to help them with a cough. We can help them by helping them to apply pressure to their abdomen to help them assist with the cough. Or there's actually a machine that can give them a little bit of an assist to, when they're ready to cough, a little machine that'll push, like a little vest that they wear that helps to push that cough out. We also can use functional electrical stimulation. It's like a pacemaker, but for your diaphragm. It delivers a shock to your muscle and it triggers it to help it move. And that can help them with respiratory dysfunction. Pretty cool, all the things we have now. Okay, so they're immobile, so keep their neck neutral and the rest of their body in good alignment. We talked about the Gardner-Wells tongs or the Crutchfield tongs back when we did traction. That's a skeletal traction that puts pins into their skull to hold their neck and their head immobile, usually used until surgery. It used to be we put people in these Gardner-Wells tongs on a striker bed, and we keep them in bed for 6, 12, 18 weeks. And now, again, the impetus is to get them to surgery quicker, to decompress, and to repair the injury through surgery so that we can get them out of bed rest quicker and that we have better outcomes from that. So our surgery would be a spinal reduction. Remember, reduce the fracture, take care of all the debris out of it and put everything back in alignment. And then we can put them in a vest or external traction, external fixator to hold them in place then as they're recovering. But this patient's still gonna be pretty immobile. We didn't fix all their function. They still have loss of motor nerves below the level of injury. And so they are gonna be in an immobilization process. And so we have to monitor pressure sites if they're in a wheelchair, if they're on a backboard, if they're in bed. We still have to watch all their pressure sites and do good skin care, make sure their nutrition stays up and everything stays dry. The patients are going to be remobilized, but sometimes it takes time. They have to heal. So over a period of time, we can give braces, we can use those electric nerve stimulators, and we can use all kinds of assistive devices that they can get up and begin to, like if they have a low lumbar injury, quite often we can put them in these leg devices that use robotics and neuron stimulation to help them walk. And so there's all kinds of very cool devices now we have to help people remobilize and live a life that is as normal as possible. Because of the loss of sympathetic tone, you have a loss of venous return during that emergent period. So again, they're going to be bradycardic. This happens mostly in people with injuries above T6. So if your injury is at T12, you're not likely to have neurogenic shock. It's going to happen with T6 or above. And they also get a lot of positional hypotension because the ability to not drop your blood pressure when you stand up, the ability when you stand up that your blood pressure stabilizes, that's a sympathetic activity. And if they lose that, then they have real positional hypotension. That's a high risk for them for falling and other problems. So autonomic dysreflexia, this is a complication after spinal cord injury you really need to know. This happens after the spinal shock. after the complete flaccid paralysis and the loss of the spinal reflexes. At some point, the reflexes are going to return. And we looked at that slide. It can happen as early as 3 or 4, 4 days they can start, but a couple weeks in, they may get their reflexes back. So this is a patient who's got a T6 or higher injury. That's the second time we've seen that magic number. We saw it here under cardiac with neurogenic shock, and we're seeing it here with autonomic dysreflexia. So that T6 or higher number looks like it might be an important one for you. So if the patient has an injury above T6, T5, T3, C, C4, whatever, then they might get autonomic dysreflexia. Every patient does not get this, but it is a serious complication that we need to be able to recognize. So if the patient does get it, we can treat it. So what happens is their sensory receptors below the level of injury are activated, and it stimulates the sympathetic nervous system. And that causes a massive arterial vasoconstriction. Arterial vasoconstriction and hypertension. The sensory receptors below the injury, some triggered the sympathetic neurons, and it sends a message. Remember, they're in recovery mode. This patient is in the acute. They're already beginning to recover. They're getting some function back. They're getting reflexes back. And they already have their reflexes back. They're getting sympathetic tone back. And so it causes hypertension, significant hypertension. And so the baroreceptors compensate, and they stimulate the parasympathetic nerves, and so the heart rate then slows. So they have massive hypertension, they have bradycardia, and above the injury, they'll vasodilate. So they'll be red and flushed above the injury and pale below the injury. So the visceral peripheral vessels don't dilate because those messages can't get through the damaged cord, but above the injury, they'll be vasodilated, they'll be red, they'll be flushed. What causes this? Remember, it's a trigger, a strong sensory trigger from below the level of injury. Pressure sores, full bladder, full bowel, any kind of unpleasant, strong stimulus can cause it. So what are we going to do? Well, first off, we have to recognize that's what's going on with the patient. The patient will probably complain of a throbbing headache. But just because someone has a throbbing headache does not mean they have autonomic dysreflexia. This patient has had a massive trauma, a major life change, total sense of self-esteem and changes all around them. A headache might not be that unusual, right? So they're going to have this throbbing headache, and we go to assess them further. We take their blood pressure and their pulse, and we identify significant hypertension. I mean 180, 190, 210 systolically, with bradycardia. And normal is 60, so we're looking at a pulse down in the low 50s, 40s, or even 30s. They'll be flushed above the injury and have pallor below the injury, and they may have nasal congestion. That vasodilation above the injury dilates the nasal vessels, so they have a stuffy nose. I can't breathe. I just have a really stuffy nose. And they have a sense of something's wrong. I know something's wrong. Everything is not normal. So what do we do? First and foremost, that high blood pressure is really dangerous. Get that head of the bed elevated. That might mean a reverse Trendelenburg, right? We're not just going to ratchet up the head. If they're still having to maintain a flat back, we're going to elevate the head of the bed. Then we're going to start hunting down the cause. We're going to look to see if their catheter is kinked, if they have a full bladder. We're going to find out where the last time they had a bowel movement is. We're going to see if they have any pressure ulcers, if they've got something kinked or pushing on them or causing some kind of discomfort, any constricting garments, a belt, some kind of like a rubber band that they wrapped around their wrist or whatever. So constricting garments, anything like that can cause this, a strong stimulus. If identifying the cause, putting a catheter in, sometimes it takes a while to get somebody to have a bowel movement, and sometimes a pressure sore can't be healed instantly. So we have to treat it. And if we identify the cause and just treating whatever it was doesn't make that go away, we need to get that blood pressure down. So we're going to use a vasodilator like hydralazine. That's trade name of Presaline, hydralazine. We also can give sodium nitroprusside or sodium or nitroglycerin. Nitroglycerin is used to vasodilate the heart, but it will vasodilate other vessels as well. Sodium nitroprusside is a drug we often give in ICU for somebody with a dramatically elevated blood pressure. I have to be cautious of this one though, because it metabolizes to, metabolizes to a poison, cyanide. It metabolizes to cyanide. So you don't want to overdose them on your sodium nitroprusside. You just want to give it in carefully titrated small doses to get their blood pressure where you want it to go. Okay, food and fluid. We want this patient to eat. We're going to drop the NG tube and we're going to keep their stomach empty. We're going to put them on proton pump inhibitors. We're going to assess them for the first 48 to 72 hours for paralytic ileus. And if they develop bowel sounds, we're going to make sure we start feeding within 72 hours. If we can't get food into their mouth, we're going to give enteral feedings into their NG tube. And if that doesn't, if they have to have it long term, they may end up having to have a gastrostomy tube. But usually they'll begin to eat on their own again. So if they can't take oral foods, then we'll do enteral. If we can't do enteral, then we'll do parenteral, which means IV nutrition, which means total parenteral nutrition, which is an IV that has high levels of proteins, high levels of carbs, and there's another bottle that'll have interlipids in it, so we can give protein, carbs, and fats in a prescribed amount with trace elements and vitamins, and so it's total nutrition, but there's some complications of it. It's a really rich glucose protein-rich formula. There's high infection rates. There's all kind of debris and emboli that can happen. We actually do a little mini unit on TPN in level 4. I'll be talking to you about that this summer. So we want to make sure their diet is high protein and high calorie. They need tons of calories. They've got healing going on. We've got soft tissue that needs to heal, and we've got spinal tissue that needs to heal as much as possible. Won't always be able to get full function back, but we should see some improvement. If they've had a cervical injury, we're going to make sure we get a referral to a speech therapist to get a swallow study done to make sure before we start feeding them orally. We want to make sure they can maintain their airway and swallow effectively. So a high cervical injury is the most likely to have problems with feeding. And then a well-balanced calorie-managed diet, because we don't want this person to just become obese now that they're immobile. We have to manage their calories and keep them at a lean, healthy weight. They're going to have to be able to move themselves around, slide across from the wheelchair to a commode, help themselves get dressed. If they have any upper body movement at all, we really want to watch their weight, because if they have to be moved by somebody else, we don't want them to be morbidly obese and have it take 6 people to move them. But if they're going to be moving themselves, we don't want them to be more weight that they can move. Okay, temperature and pain. Make sure they have appropriate covers, but also make sure you have a fan in the room. Make sure you might need a heating and cooling blanket. It's if they have nociceptive pain. Remember, there was neuropathic pain, nociceptive pain. If they have nociceptive pain, NSAIDs can help with that, or opioids. We try not to give everybody heavy-duty opioids, but anti-inflammatory drugs like Nuprin, Advil, all of those. Visceral pain is pain in their organs, bladder pain, bowel pain, pain from a urinary tract infection. Stasis can cause gallstones, so cholecystitis can cause you pain. So if they have visceral pain, we're going to try and figure out what's causing it and then treat the cause. So is it constipation? Is it an infection? Is it gallstones? What's going on? What's causing that deep visceral pain? If it's neuropathic pain, remember that's the shooting, tingling, numbness pain that comes from the injury, direct injury to the neurons with the spinal cord, and 3 dermatomes below it. Hot, shooting, burning. Most commonly, the drug we give for that is Lyrica, pregabalin. Lyrica, it's a good drug for neuropathic pain. All right, bowel and bladder training. These patients have to learn to reuse their bowel and bladder. You've got a neurogenic bladder. Usually they have an over-distended bladder. They don't have the sensation of when they need to go. So they get reflux up into the ureters, and often they'll get recurrent urinary tract infections. Initially, we're going to put a Foley in. Patients that have spinal cord injury, they're going to be on bed rest. We're going to be doing emergent care, emergent acute care, and we're not getting them up to go to the bathroom. They're on a backboard. So initially we're putting a Foley catheter in. If when they get to the point the catheter can be removed and we've got them moving into rehab, we'll be doing clean, intermittent catheterizations 6 times a day. Clean cath. Now, that's a new concept for you guys. Foleys, they're sterile, right? The patient is going to learn to self-catheterize 6 times a day, and they use clean technique for it. If they are male, they can use a condom catheter. That won't help empty their bladder, but it will take care of a bladder that has having overflow and dribbling. It will catch that urine. We can give, if they have a spastic bladder, we can give the oxybutynin for bladder spasms, pretty common drug for bladder spasms in the general population. And if they have a spastic neurogenic bladder, then we can give them oxybutynin for that. Some men, after a spinal cord injury, will get a prolonged erection called a priapism. If it lasts longer than 2 hours, we need to call the provider and help get some relief from that. They need, if they have the reflux and the retention and the stasis of urine, puts them really high risk for urinary tract infection. So we want to help prevent that, give them lots of fluids, try and stay away from Cokes and things like that if at all possible, because we just want to give them water and things that are going to keep their, maybe cranberry juice, could keep the acid-ash balance right in their urine, and make sure they're well hydrated. So there's a whole bladder and bowel training program that they're going to go through. Then they have a neurogenic bowel. If they have that was neurogenic bladder. If they have a neurogenic bowel, they have usually a flaccid bowel. If they have a flaccid bowel, we'll use rectal stimulant suppositories in the evening. And then in the morning, we can generally do manual stimulation, evacuation, and get them to have a bowel movement. We might do small volume enemas. So quite often the patient just requires a glycerin suppository, a lubricant suppository, to help facilitate the relief of the constipation. We'll give them stool softeners to make sure they don't get the hard stool that gets stuck up in there. If necessary, they can have osmotic laxatives. Osmotic laxatives cause a shift of water, taking water from the vascular space to the bowel space to eliminate. That's harsher than stool softeners, glycerin suppositories, and a rectal stimulant suppository. Those are harsher. The patient, however, isn't going to forever have us doing things like that to them. They're going to have to learn to manage their own bowel program. So they can do, if they have hand and arm movement and they're a paraplegic, they can do their own digital rectal stimulation. They can insert their own suppositories. They can learn how to manually evacuate their bowels themselves, removal of an impaction themselves. Again, to keep them from being constipated, high fiber, increased fluids, warm fluids. Normally we'd say walk and move more. That's not possible for this patient. So increase the fluids, give them warm fluids, a high fiber diet, as much activity as possible, and don't be impatient with them. Make sure that you have lots of time, because it's just going to take them a while to make this happen. Patients that are going through a bowel and bladder training program need to learn to use a transfer board or transfer rails to get from their wheelchair to the commode, because they're going to need to learn to transfer themselves. There's a whole bowel and bladder program that if you go into this specialty, if you work with spinal cord injury patients as a life career, there's whole bladder and bowel training programs, but these are the basics. And again, we mentioned stress ulcers earlier, so we have to make sure that we help prevent that. I had a friend who became paralyzed, and it was like 8 months later he got his stress ulcer. Just the chronic stress of his lifestyle adaptation gave him a bleeding duodenal ulcer. They also, if they're in the hospital, immobilized on a backboard with traction or post-operatively, and in long-term treatment to get them rehabbed, there can be a lot of sensory deprivation, and that can cause confusion, isolation, loneliness. So we want to make sure we do our good nursing care, reality orientation, make sure they have adequate visitors, provide them with diversionary activities. Once they're discharged from the hospital or the rehab facility and they're going to home, they can get home physical therapy, home occupational and speech therapy, home pain management. We're going to, again, continue their bowel and bladder training, make sure they understand all the sequela to that they can manage that on their own. They need to really understand pressure prevention and pay attention to their own skin and know that they're sitting on gel pads or on egg crates or they have sheepskin or whatever they need to relieve pressure. They need to be very aware of that. And they're going to need some form of recreation. There's wheelchair basketball races. There's all kinds of stuff out there. It just depends on the level of injury they have and how much function they have that they can be involved in. So as a whole, patients with spinal cord injury have an overall reduced life expectancy compared to an average American adult. There's higher mortality in spinal cord injuries that first year post-injury. There's a much higher mortality that year. Pneumonia, bleeding ulcers, blood pressure problems. There's also a high level of depression post-spinal cord injury. They're really at risk for mood and affect disorders, and they're high risk for suicide. So you would want to constantly be monitoring their mood, ask them questions, and if they start to give you hints of suicidal ideation, you want to remember all that stuff we talked about in mood and affect, evoke a no suicide contract, get them to agree, talk about their plan, and help them to process through their emotional affective disorders and make sure we get them stabilized on an antidepressant if they need it. That's the end of the spinal cord injury section. That's actually in your textbook in chapter 60. The whole first part of that chapter is on spinal cord injury. So I know you'll benefit from learning all about it.